そうですね。多分自分の発表スライドを出すのができない。なんでだ
Okay. So now you can see your screen and the slides very well. First of all, thank you very much, Dr. Hara, Dr. Okuno, Dr. Shinhab, Dr. Koda, Dr. Kohara, for accepting our invitation. It's our great honor and pleasure to have you in our annual conference. Now I will give the Professor Muhammad Azab will welcome you and start the session.
Thank you, Professor Hara and your team for participating in our conference. We are glad to get you with us. Your presence will enrich our conference, and we are very glad to get you with us. Thank you very much for participating and accepting our invitation.
See, Dr. Hara, could you give opening remark, short opening remark? Hara Sensei.
Please wait.
Yeah.
Hara Sensei.
Oh, it's...
Hara Sensei. オープニングリマークを言ってくれているの。もうあとだ。
Yeah, not that tricky. Dr. Hara, please opening remarks, please. Yes.
Hey, I'm Kazuhara from Aichi Cancer Center. It's a great honor to give a lecture, and I want to join this meeting, Egyptian and Aichi Cancer Center meeting. This is a very wonderful meeting. Every year, this time is maybe third time or fourth time.
Yes.
Maybe.
Yes, third time.
So I'm so excited now.
Yeah.
Thank you, Morris, and thank you for Egyptian Society.
Yeah, thank you very much, Sensei. Okay.
Thank you, Professor Hara, for accepting our invitation, and we are glad to get you with us and your team. Welcome.
Welcome too.
So now we will start by first lecture about EUS training in Aichi Cancer Center. The presenter is Professor Nozomi Okuno, actually one of my teachers. I get honored to learn and work from here, with here, for around 4 or 5 years. She will speak about EUS training in Aichi Cancer Center.
Okay. Hi, everyone. Can you hear me?
Yes, we can hear you very well.
Okay, thank you. Today I will talk about EUS training in Aichi Cancer Center Hospital. Thank you for giving me such a great opportunity. Okay, so let's start. Oh, sorry. Interventional EUS, such as diagnostic EUS-FNA, have seen a remarkable expansion in their roles, including tissue sampling for comprehensive genomic profiling and the spread of EUS-guided biliary drainage. However, these diagnostic and therapeutic techniques often depend heavily on the skills of the operator. Therefore, education is crucial. We welcome trainees from both domestic and international, and I present our educational methods with videos. This is our team, our pancreatic biliary group. There are 6 trainers and 6 domestic trainees and 1 foreign trainee from Egypt. His name is Hossan. This is our slide, the system of Aichi Cancer Center Hospital. EUS trainer is 5 trainers, and there are 4 or 6 domestic trainees and 1 or 2 foreign trainees. And the ERCP, we performed 450 cases per year. And the screening EUS, 1,200 cases per year. And the interventional ES, we performed 700 cases per year. ESFNA and EUS biliary drainage and therapeutic EUS, about 100 cases. For example, EUS ethanol injection or EUS cyst drainage or something. This is weekly schedule of trainees. And we have two very important conferences, pre-operation conference and pathological conference, are very educational and beneficial for trainees.
Thanks, Mavich, you have both really identified the lymphocytes. Can you do talks covering this cystic lesion? And here you see the pancreas.
This video shows pathological conference. After presentation of gastroenterologist and surgeon, the pathologist explains in English. Our pathologist is very kind doctors. And another feature is we focus on screening EUS. Therefore, we perform screening EUS every day. Monday, Tuesday, Wednesday, Thursday, Friday, every day we perform EUS screening. And we try to perform the screening EUS in the same way, same method, like singing a song. We turn on a microphone and perform EUS while explaining the standard visualization. This video, a trainer performs EUS screening. He explains with microphone, like this. And the trainee, he is Hosan, and he performs EUS screening. Like trainer, same method. Microphone, and he explains in English. And Dr. Harat created the teaching materials for EUS screening in English. The goal is, this is a goal for trainees. At first perform EUS assistant, and the next perform EUS screening. And after that, they received Dr. Harat's check. And check basic skill for EUS screening and diagnostic insight. And after pass the Hara check, they can start EUS FNA and finally perform therapeutic EUS. And very important point is assistant and complete screening EUS. Learn the basics is very important. And after 30 cases, they will be able to complete screening EUS at over 90%. So EUS screening and diagnostic eye is most important, we think. This is Dr. Ahmed's story. He stayed here from April to October 2023, only 7 months. And at first, he had no experience of EUS and ERCP when he came to ACC. So he started from assistant, and after assistant, started screening EUS. So EUS assistant objective is understanding the standard EUS screening and anatomy of EUS, and the choice of image and measurement of the lesion. Develop the ability to examine the EUS convex image is important for assistants. And Next step is screening EUS like, as a first operator. Complete screening of EUS. And the evaluation point is explanation of the scanning procedure and the detected image in English. And when he start operator, he is Dr. Tachi from Ghana, and he start assistant. And Dr. Ahmed already teaching him. So this assistant to operator and operator teach to assistant, both very important. And after that, after Dr. Hara check, he start EUS-FNA. This is 90 gauge FNB needle, so puncture is most difficult needle, but he could perform EUS-FNB like this. And visualization of target and perform EUS-FNB and check rows. So rows is very useful for trainees. And after EUS-FNA, trainee check loads, rapid on-site evaluation with cytologist by themselves. And after that, they can think this area is good or not. So perform FNA same position, we have to change another position. He can change. So, and after that, they can perform therapeutic EUS. Therapeutic EUS include EUS HGS and EUS cyst drainage and EUS GBD. So, next my presentation is EUS HGS. EUS HGS is just 4 steps. At first, detection, and the next puncture, and the third step is dilation, and the fourth step is stent placement. So just only 4 steps. So this is very easy for training. But some point is a little bit difficult for training. First, decision of puncture position, and the next, puncturing narrow bile duct, because intrahepatic bile duct is sometimes so narrow, and the insertion guide wire is sometimes difficult. And the dilation, insertion device is a little bit difficult. And finally, stent insertion and placement is a little bit difficult for trainees. So, we changed our method for easy and for safe for trainees and trainers. So now we perform B2 EUS HGS. We use forward viewing EUS or Fuji EZ740 UT. This scope, we can puncture B2 easily. So now we use B2, we perform B2 HGS by this scope. This is our training. And 3 or 4 years ago, we performed B3 HGS. But B3 HGS is sometimes difficult because B3 has a shoulder. B2 is very straight, but B3 is a little bit acute. So insertion device is a little bit difficult for trainees. So now we changed our strategy for B2 HGS. And we create the new dilation device. This device made from his idea, Dr. Hara's idea, just rotation, but we can perform dilation. This is a new dilation device. Name is Turnus ES, and just clockwise rotation. Like this, we can dilation. So no need to pushing hard. So this device is very useful and very easy for training. So now our USHGS strategy is this. For easy and safe HGS, beads puncture by Fuji scope, and the needle we can use 22Z needle. 22Z needle is useful for very small intrahepatic bile duct. And the Tornas AP, and this is Tornas new dilator method, and we insertion the very small device Furukawa cells. So this slide compare expert and non-expert on the beads USHGS technique. Expert perform 100%, but non-expert, but they can perform USHGS completely, 74%. And the early adverse event rate is not significant difference between two groups. This slide shows the timing of switching to expert. Most difficult is puncture. So 21% trainee to trainee cannot puncture, so change it to trainer. But after that, dilation and stent insertion is only 7 cases. So if a trainee can puncture, almost all cases a trainee can USHGS completely. So in our center, trainee of course perform beads HGS. Dr. Hamed first no experience of EUS, but finally he performed USHGS. This slide shows the number of the procedure in each trainees. US screening, USFNA, USHGS, all procedures they can perform so many cases. So during a short time, they can focus on US and the US procedure. This is very important. So our center's trainee finally can perform USFNA and USPD. So this is my summary. The same educational step-up system for all trainees. This is very important for education. Thank you for your kind attention. My presentation is finished.
Thank you very much, Dr. Okuno, for your nice and informative presentation. So, any question from the panelists or from the floor? For free. Dr. Okuno?
Yes.
Professor Amjad asked about the fees of the training course in IG, but already I answered it's for free. No, the trainee don't have to pay for training, just for his accommodation, right? Right?
Yes, of course.
Yeah. So, I have a question.
Oh, yes.
So, how Dr. Hara check the trainee can pass from one step to other? Is there some checklist, or how can he check the trainee can pass from screening to FNA? How can he evaluate?
I see. Maybe this question is difficult for me. Only Dr. Hara check. But maybe I think he checks US screening, standard US screening visualization, and the eye, trainee's eye, can diagnose or not, and the standard screening method.
Yeah.
And if they can pass, they can start USFNA.
Yeah, but he must pass 3 stations: gastric station, and D1 and D2. He could perform
all.
perfectly. Yes.
All. Stomach to D2, all.
Yes, okay.
Can I ask a question?
Yes.
Thank you, Dr. Okuno, for training our dear colleagues and dear brother Muaz. And you didn't say about the cystogastrostomy. What about cystogastrostomy? In the training of you say about the interventional EUS, and you didn't give us the idea about cystogastrostomy.
So trainee can perform EUS guided cystogastrostomy in Aichi.
After what number of cases you can start?
Yes, after performing USFNA, they can perform EUS cyst drainage.
Yes. So HGS and cyst drainage.
Yes, HGS and the cyst drainage, and
more complicated.
Some abscess drainage, like liver or spleen, easy case.
How about CDS?
CDS is they cannot perform because CDS is high risk.
Risky.
So in our center, US guided pancreatic drainage and the US guided CDS.
Yes.
These two procedure only trainer perform.
Yes, stuff. Yes, I know.
Yes. CDS and PD.
Okay. So, دكتور ندري. دكتور عبد الرحمن اتفضل.
بس انا هو يعني الليرنينج كيرف هم حاطينه just 30 cases for screening EUS. That guidelines, the learning curve for screening EUS 30 cases, then EUS FNA and FNB?
Yeah. So 30 cases observation is enough? Okuno Sensei?
This is a very good question. 30 cases is one goal, but not enough. But after 30 cases, procedure and eye is better than starting time. So this is the one goal, and after 30 cases, they perform EUS screening more and more, and after that, Dr. Hara's checks.
Okay. Another question that is, there is any background endoscopic techniques for the EUS trainee is scheduled for his competent in upper lower endoscopy, or just from day one can do EUS without background intervention?
Yes. So trainee must be learn about EGD and colonoscopy first, right?
Yes, because
basic
is important.
Yes.
So when they start EUS, upper and lower endoscopic technique is needed. But I think no need ERCP technique.
Yes.
ERCP technique and EUS technique is quite different.
Yeah.
So only EPD and colonoscopy enough, I think.
Okay. Thank you, Okuno Sensei. Thank you very much.
Thank you, Muaz.
Thank you very much, Mr. Okuno. You will introduce Professor Hiroki Koda. He will speak about EUS fine needle biopsy for comprehensive genomic profiling.
Dr. Koda, can you hear us?
Can you hear me?
Yes. Hi, Koda Sensei.
Okay, let me share my PowerPoint slide.